بسم الله الرحمن الرحيم. الحمد لله وحده والصلاة والسلام على من لا نبي بعده. Assalamu alaikum. I am Dr. Zakaria Gnoon, consultant in diagnostic radiology, and the lecture of today will be an approach to the differential diagnosis of cavitary lung lesions. So what are the key objectives of this lecture? First, provide insights for accurately characterizing cavitary lesions. Then ensure differentiation between true cavitary lesions and mimickers. Offer a 10-step approach to evaluate cavitary lesions and review the underlying causes of cavitation, including clinical and imaging characteristics. How is a cavitary lesion defined according to the Fleischner Society? A cavity is an abnormal gas or fluid-filled structure. It can contain fluid in its entirety or a mix between fluid and gas. It has a thick wall. This is very important, not thin. It's a thick wall, often irregular wall, typically resulting from the expulsion or drainage of necrotic material via the bronchial tree. It may be unique or multiple. It may be also isolated or associated with adjacent lung pathology, and a gas fluid level may be present within the cavity. So what are the 10 steps for evaluating a cavitary lesion? First, you have to confirm that there is indeed a cavity, excluding other mimickers like cysts, emphysema, bullae, and cystic bronchiectasis. Then assess the wall characteristics, its thickness, irregularity, either internal irregularity or external indentations, and any enhancement within the wall. Look for any intracavitary material, either soft tissue, fluid, debris. Look for also an enhancing focus within the wall, which could represent a pseudo-aneurysm or neoplasm. For the pleural-based lesions, look for any pleural communication, which could correspond to pneumothorax or bronchopleural fistula. Search for any surrounding changes or ancillary findings like rib involvement and consolidation. Of course, correlate with the history of the patient, the clinical presentation like age, smoking, travel, and immunocompromised status. Assess the temporal evaluation. Is the cavity acute or chronic? Locate precisely the cavity, which will help you in the differential diagnosis. And of course, the number of the cavities. Is it single or multiple? We begin with mimickers of cavitation. What are the common mimickers of cavitary lesions and how are they defined? We begin with the cyst, which is a circumscribed, well-defined, thin-walled. This is very important. It's thin, not thick, air-containing structure in the lung parenchyma. Then we go to the emphysema, which is irreversible enlargement of air spaces distal to the terminal bronchioles. So the really thin wall of the emphysema lesions will correspond, in fact, to the walls of the terminal bronchioles. Bullae are thin-walled, air-containing cystic structures lined by collapsed lung parenchyma. So one of the key features of bullae is the atelectasis of lung surrounding the bullae. Lastly, cystic bronchiectasis, which is irreversible bronchial dilatation with bronchial wall thickening. So the wall of the cystic bronchiectasis will correspond to the dilated bronchus. We go to the wall characteristics. What should radiologists look for when assessing the wall of a cavitary lesion? You have to know that wall thickness is not really a reliable indicator of benign versus malignant etiology. Like in this example, you have an air-filled cavitary lesion with relatively thin wall. This was a cancer. In this case, you have a really thick walled cavitary lesion, air-filled, with internal irregularity and speculated indentations on the outer margin. This was a granulomatosis lesion. So, like we said, wall thickness is not really a reliable indicator. A more reliable indicator would be the enhancement. Malignancy should be suspected if enhancement measures more than 10 millimeters. Also, irregularity. Irregular internal walls and outer wall indentations are more suggestive of malignancy. Like the example that we saw, lung cancer may show thinner walls compared to granulomatosis, but irregularity and indentation are more common in malignancy. Then look for any intracavitary material. What does the presence of intracavitary material suggest? If you have soft tissue material, it may indicate superinfection like aspergilloma or aneurysm or a clot or neoplasm. Fluid levels suggest necrotic material or infection, but you always have to rule out pseudo-aneurysm. For example, Rasmussen's aneurysm in tuberculosis before biopsy. For this matter, you have to look for any enhancement enhancing focus in the wall of the cavity because of this Rasmussen's aneurysm, which is a specific type of pulmonary artery pseudoaneurysm seen in tuberculosis, and you have to exclude it before performing a biopsy because it could rupture. Next, look for any pleural communication. What complications can arise from a cavity communicating with the pleural space? Either pneumothorax, which is air leakage into the pleural space, like this is a hydropneumothorax, or bronchopleural fistula, which is abnormal connection between the bronchus and pleural space. Next, look for any surrounding changes and ancillary findings. So how do surrounding changes help in diagnosing cavitary lesions? So if you have a pleural-based cavitary lesion and you have an adjacent rib involvement like sclerosis or cortical irregularity adjacent to the cavity, it may suggest that this cavity is in fact a squamous cell carcinoma. On the other hand, if you have some consolidation around the cavity, it may indicate an infection like tuberculosis. You also have to correlate this cavity with the patient history and clinical presentation. For example, lung abscess will occur in older age during alcoholism, in diabetes and drug abuse. Tuberculosis will occur in endemic regions and during HIV infection, for example. Assess temporal evaluation, because an acute cavity will differ from a chronic cavity. An acute cavity less than 12 weeks will be likely infectious. A chronic cavity, in chronic cavities, you will have to consider neoplasms or autoimmune diseases like rheumatoid arthritis, granulomatosis. Then locate the cavity. How does the location of a cavity aid in the differential diagnosis? Post-primary tuberculosis occur in apical posterior segments of the upper lobes. In septic emboli, it will be located in subpleural nodules, and for aspiration lung abscess, it's the posterior segment of upper lobes or superior segment of the lower lobes. Then number of cavities. How does the number of cavities help in determining the etiology? A single cavity, you will have to discuss cancer, bronchogenic carcinoma, or pyogenic abscess. In multiple cavities, it can occur in metastasis, tuberculosis, and septic emboli. Some key takeaway notes for everyday practice. First, confirm the cavity. Always differentiate true cavitary lesions from mimickers. Then assess wall characteristics. Suspect malignancy if wall enhancement is more than 10 mm, or if the wall is irregular with indentations. Then look for any intracavitary material, soft tissue material suggesting superinfection, aneurysm, clot, or neoplasm. Look for any enhancing focus to rule out pseudoaneurysm before biopsy, especially in tuberculosis. Look for any pleural communication. Be aware of complications like pneumothorax or bronchopleural fistula. Search for any surrounding changes. Look for example, rib involvement or consolidation to narrow the differential. Always correlate with the clinical history of the patient, including smoking, travel, and immunocompromised status. Assess temporal evolution, because the differential diagnosis of acute cavities less than 12 weeks will differ from the differential diagnosis of chronic cavities more than 12 weeks. Location matters. Upper lobe cavities suggest tuberculosis. Subpleural cavities suggest septic emboli. And of course, the number of cavities. Single cavities may indicate cancer or abscess. Multiple cavities suggest tuberculosis, septic emboli, or autoimmune disease.